My name is Alexandra Ziemann. I'm a Senior Research Fellow at the Centre for Healthcare Innovation Research at City, University of London. And in this presentation, we're looking into how rapid implementation was operationalized during the COVID-19 pandemic by academic health science networks, who are intermediary organizations with the official mandate for spreading innovations across the national health system in England. One could argue that rapid implementation approaches are quite pertinent in implementation science, giving the field's goal to close the no-do gap. James Smith and colleagues have recently conceptualized rapid implementation and suggested a definition for rapid implementation as providing the best possible evidence-based practice of a program or intervention to those who need it, with speed and efficiency, by redefining rigor and adapting both methods and design. So that's the conceptual side of things, but how can rapid implementation be applied in implementation practice? And the pandemic really posed a natural laboratory for us to learn more about how rapid implementation could be operationalized. And that's what we set to find out with this study by studying the spread activity of academic health science networks, or AHSNs, during the first 3 months of the pandemic. There are 15 AHSNs in England, and they were set up by the National Health System. Each is working across a distinct geography and population, and they are nationally organized as AHSN network. AHSNs have the official mandate not to do implementation, but to facilitate implementation and spread. So they are really intermediary organizations, supporting organizations in their local health and care system to adopt innovations that could come from innovators that sit in academia or the health system itself or industry. And they work across the whole innovation journey, as you can see here on the right, from the discovery and development of innovations through to the deployment or implementation of innovations. So who better to study when it comes to exploring the spread of innovations and how that's solved? So this study on the rapid spread approaches during COVID-19 was part of a wider mixed method study that explored the spread approaches of AHSNs in general, or business as usual before COVID-19 hit. And we did this study in collaboration with 2 AHSNs in Wessex and the southwest of England. And it was co-funded by the AHSN Network and NHS England and ran from January to November 2020. And for the study that was exploring the spread activity during COVID, we applied qualitative thematic analysis to AHSN documents and to transcripts of 3 Zoom focus groups that we organized in June and July 2020. And those were organized with 26 staff members from academic health science networks from 14 out of 15. And the activity that we wanted to cover by these focus groups was their spread activity during March and June 2020, so the first wave of the pandemic in England. And you can access the study reports if you're interested for both the COVID study and the wider study through the QR codes that are displayed here. Well, coming to the findings, COVID-19, as we all know, caused a massive change in the context for spreading innovations. Change in focus on disease or certain settings, everything and everyone was suddenly rallied around this common goal of fighting the pandemic, and solutions needed to be found for certain settings more than others, for example, care homes. There was an urgency for change and this need to find solutions to find the pandemic quickly, and also the rules, for example, social distancing, came into force overnight, so very quickly. And this also came with a change in mindset of those involved in spreading innovations in terms of accepting risk. It was more important to have a solution quickly, even if that meant accepting solutions that might not have been proven completely for a particular setting or for a particular use case. And this quote from an AHSN staff member in the focus groups illustrates this. So I think the pandemic, if nothing else, has created a sort of urgency in the system and a bit more risk-taking and less risk aversion, which I think, as long as we're rigorous and diligent with governance, is great. And remote working and social distancing changed, on one hand, of course, the way of working in healthcare, but also the way that AHSNs had to work themselves. And it required rapid solutions enabling remote care and remote working. There was a change in governance structure in the NHS, so new structures were put in place, national or regional policy levels, to enable quick decision making, and these AHSNs found to really help them enabling rapid spread of innovations. And this is also linking back to this point about reduction in risk awareness to trying out new things. So how have AHSN adapted their approaches to spreading innovations in response to this changed implementation context? First of all, they applied a more agile approach to meeting the changing local needs in a quick fashion. And this quote illustrates that. So we literally hit the black book and thought, who can we call? Who can we literally pick up the phone to and say, clearly you have different needs right now. What are they? How can we help? So AHSN relied on existing solutions a lot and their existing networks and relationships to quickly identify, adapt and implement innovations. For example, this new focus on care homes during the pandemic and the need for remote care in care homes saw AHSNs to adapt an existing innovation to share medication information electronically that they had implemented in hospitals in the past and that were now extended to care homes, to include care homes. And the necessity of working remotely actually proved to be increasing the efficiency of AHSN spread activity. What would have been done face-to-face in the past, engaging with stakeholders, offering training, organizing dissemination events, was now done online. And that saved a lot of time and it was much more inclusive and really reduced barriers of access of certain stakeholders to take part. And while AHSNs increased the pace in spreading innovations and facilitated the implementation of new solutions, they really wanted to make sure to build in evaluations for quality assurance. And this also proved to be another window of opportunity for them, really, to generate new evidence on those new solutions. And this quote illustrates this. As AHSNs, it's really important that when something has happened really quickly, we make sure that we are doing what we can with the system to extract learning at every possible moment, then helping the system to optimize the changes that have been made sustainably afterwards. So to conclude, what have we learned about how rapid implementation can be operationalized in practice? And it's really a combination of remote and agile ways of working and the new enabling context that allowed for more rapid implementation of innovations during COVID-19. And while increasing the speed and efficiency of spreading innovations, AHSN really aimed at balancing still quality and rigor by building in those evaluations. And the last point is around what AHSN staff were telling us about which key approaches they would like to take forward after the pandemic. And those are really around the progressively proven remote ways of working and the increased focus on adapting strategies and to increase implementation efficiency and pace after the pandemic. And that's it. Thank you very much for watching. Happy to hear from you and discuss any questions and comments. And please do have a look at the full reports. Thank you very much.